So what we're going to do today is finish up with hematology. So I just want to go into a little bit more detail on chapter 33 about hematology, and then we'll spend a little bit of time talking about the hematological cancers, the oncology part of hematology. So as a recap from yesterday's lecture, I want to make sure that you understand about the bleeding disorders. I wanted to talk just a little bit more about that. The thrombocytopenia, hemophilia, and DIC, disseminated intravascular coagulation. Those are the three conditions you're probably going to see in the hospital that is going to make your patient bleed. And you need to watch for that. Keep in mind that your platelets, normal platelets, are 150 to 300. Typically, your platelets can actually get fairly low before you'll start seeing some symptoms and before there's some actual problems with your patient. So, which is good news. But I did want to point out a couple things about thrombocytopenia in particular. And remember, the word thrombo is clot, or platelets, another word for platelets. Cytovessel, and penia is not enough of something. So there's not enough platelets in the vessels, basically. And I'm not going to spend time going over the clotting cascade. You'll need to remember that or review that from physiology. But if you'll recall, there's several a lot of steps, like more than one step in the clotting cascade. And you can have a problem anywhere along the cascade, and it'll lead to bleeding disorders. But there's a couple different reasons why those bleeding disorders will occur. And I just want to point them out to you, just so that you're aware of why bleeding disorders can occur and what to watch for when you're in the hospital. So the first thing with thrombocytopenia, there's three types. There's immune thrombocytopenia purpura, ITP. There's heparin-induced thrombocytopenia, that's known as HITS, HITS, and there is thrombotic thrombocytopenia purpura, TTP. And basically those are just three different causes of thrombocytopenia. The one that I wanted to point out, because the immune one is like an autoimmune disorder, the thing that I wanted to point out to you guys, because you'll see it a lot in the hospital, is HITS, this heparin-induced thrombocytopenia, because a lot of your patients in the hospital are put on heparin in order to prevent clots, which is a good thing, and there's a small segment of the population that will actually develop antibodies towards the heparin and then completely overcompensate, and then they start bleeding from everywhere. So if you have a patient who's in the hospital and they're getting IVs, and they're also getting heparin, maybe a post-op patient or something like that, and all of a sudden they start oozing from those IV sites, they might start getting some nosebleeds, epistaxis, they might start coughing up blood, things like that. It could be that they're developing HITS. Patients who develop HITS can never have heparin again, because basically they're allergic to it, is really the bottom line. They have an allergy to heparin, so to speak. It's really kind of an autoimmune thing. But if you think of it like that, so they need to wear bands that say that they're allergic to heparin, so that any other time that they're in the hospital, or even if EMS comes or something like that, they can't have heparin. So just keep that in mind. The rest of them you treat very similarly. You treat all of them the same, like you try to fix whatever the cause is. Sometimes if there's not a cause, like if it's an autoimmune process, then you just have to be more cautious with bleeding prevention and things like that. There can be some foods and some drug interactions that will actually lead to thrombocytopenia. Alcohol can lead to it. Digoxin, which is when we talk about cardiology things, tons of patients are on Dig. Some of those patients can develop some thrombocytopenia from that. The ITP, the immune one, that's the most common kind, and really what happens there is that there's an abnormal destruction of the circulating platelets. So your normal platelets that are in the bloodstream, they should be lasting about 8 to 10 days. In ITP, it's lasting about 1 to 3 days. So the platelets, they're there, but then they just, they die sooner. So there's not as many mature platelets available. Onset of that is usually gradual. Anyways, the things that you need to watch for in your patients who have thrombocytopenia, they're going to probably have some anemia, bleeding tendencies. They can also have some fever, some infections like renal abnormalities and things. So anyway, just that's just a condition that some patients are going to have, and you're going to have to just be really cautious with bleeding. The other thing, let's see, what else do I want to tell you about that? I already told you about that. I told you about that. The other thing with thrombocytopenia is one thing that they can do is they can transfuse a patient, give them more platelets, but that's usually a last resort. They usually wait until the patient is fairly low in platelets. One of the treatments is to give immunoglobulin, which is like an immune booster. It actually boosts the patient's immune system. Corticosteroids are often used to help in the treatment of the thrombocytopenias. And I think that's all I wanted to tell you about thrombocytopenia. Hemophilia, we talked a little bit about hemophilia yesterday. Hemophilia is a genetic disorder that leads to bleeding. There's two kinds, hemophilia A and B. You don't really need to know that. It's more common in males, and it is similar to von Willebrand's. And your book does a pretty good job of talking about hemophilia versus von Willebrand's. And I think I saw in your in chapter 33, there's a really good diagram of the difference between hemophilia and von Willebrand's. Basically, what happens is that there is a difference in where the problem occurs in the clotting cascade, but the results are kind of the same. Oh yeah, hemophilia starts on page 926. See that figure 33.5 on page 926? That is really common in people that have hemophilia. They tend to bleed into their joints a lot. Oh yeah, here it is. Versus von Willebrand. So I'm on page 928, figure 33.6. Those are really the two differences. So you can see, like in hemophilia, the problem is really down at the bottom where the fibrin clot breaks apart too soon, so it doesn't hold the fiber together. Von Willebrand's, the platelet plug doesn't form as well, but ultimately the problem is both patients are bleeding. So that's really what you need to know about the difference in hemophilia versus von Willebrand's disease. And let's see, what else did I want to talk about? That's kind of it. I'll show you some pictures. Oh, here's another thing. In your patients who have any of these bleeding disorders, you need to be careful when you're giving them injections. IM injections can lead to massive bleeding. I've got some good pictures I'll show you in class. But you need to be careful. So if they have to have an IM injection, you really need to do like ice afterwards and compression afterwards, because just that tiny little injection can lead to massive bleeding that's not commonly seen in other people. DIC is, that is a condition that it results from an abnormally initiated and accelerated clotting cascade. And it always has an underlying disease condition. So you're going to see this one in your patients who are in the hospital who have some other disease process going on. This one usually comes on really quickly. Your patients aren't going to come in with this. They will be in the hospital for something else, and then you'll notice that they're starting to bleed. Kind of an ominous sign. It's not. There's no real specific clinical manifestations of this, other than all of a sudden your patient will start oozing all the time. You will want to get your diagnostic studies to find out what is their PT, PTTs, INRs doing, and then the quicker you can diagnose, the quicker you can identify that somebody has DIC, and then start treating it. You want to stabilize whatever the underlying cause is. And treatment is a little bit controversial. There's a lot of different kinds of therapies that they're doing for DIC. The thing for nursing is minimizing the bleeding risk. So I think that's all. I think we're good with chapter 33. Did I tell you yesterday about taking aspirin? The half-life of aspirin is about 7 to 10 days, and sometimes patients, that's this long, which is good. Aspirin is a great blood thinner. A lot of patients take an aspirin a day. It's really good for cardiovascular health, but it can precipitate platelet disorders. And patients who are taking NSAIDs, the Motrins, ibuprofens, Advil, and like any of the non-steroidal anti-inflammatories, that can also inhibit platelet function. So if your patient has been on NSAIDs, the NSAIDs only last, like around 4 days. But if your patient, the thing to keep in mind is if your patient is going for a procedure, like for surgery or something, you need to stop those ahead of time because it can actually precipitate a platelet disorder. End-stage renal disease, patients who have renal disease, that can reduce platelet function, so this becomes more of a problem in your patients who have kidney disease. Be careful. A lot of people take herbal supplements and they think that they're doing wonderful things because it's holistic and they're taking herbs and that kind of, most of them are good, but too much of anything can sometimes not be good, and some of those herbs can actually inhibit clot and platelet formation, and so it can actually lead to bleeding disorders. So when you're getting an intake assessment, find out what herbal supplements your patient is taking, what kind of foods they're eating, because some of them that are high in vitamin K and some of the other herbs, there's a good chart on chart 33.9, I don't know what page that's on, that has that lists some good herbs and foods and stuff you need to ask your patients about. Chemotherapy can wipe out blood cells and platelets, so you need to watch for your patients who are on chemotherapy to get bleeding disorders and some of the medications. Okay, I think I told you, we talked thrombocytopenia, DIC, von Willebrand's, hemophilia. You know what's sad about hemophilia is it shows up in little kids because it's a genetic thing, so you're born with it. And then they have to avoid contact sports, which is a little bit annoying because it's more common in men, and they, so then they can't do like the football, hockey things that can lead to bleeding disorders. So, also with your bleeding disorders, patients who have clotting disorders, now we're talking polycythemia, too many blood cells in the vascular system. You want to do things to prevent clots, and that's going to be things like you don't want them crossing their legs because that's going to inhibit blood flow. When they're on long flights, have them stand up and walk around and do constant assessments for DVTs, PEs. Teach your patient what the signs and symptoms are of DVT and PE. And have your patients who have polycythemia, too many platelets, be really active, drink a lot of water. I think we talked a little bit about that yesterday. Okay, let's move into chapter 34, and we'll just real briefly talk about, I know I say real briefly and then I go on and on and on, about the cancers, the hematological neoplasms. And if you remember from yesterday, neo is new growth, neoplasma is another name for a cancer, like a tumor, is a neoplasm. Okay, so hematological, neoplasm, blood cancer. There are two major types that I want to tell you about. The leukemias and the lymphomas. And often these are associated together, and there's like a leukemia lymphoma society. So they're usually together because both of them are the hematological oncologies, and these are the malignant ones. It's like it's a cancer of the blood, the hematological system. So let's start with the leukemias. Okay. Now, leukemia, and if you'll remember from yesterday, L-E-U-K, leuko, those are the white blood cells. And so this is a cancer of the white blood cells. There are 4 kinds of leukemia, and it really, really matters what kind of leukemia your patient has to determine their outcome. Some of them are extremely aggressive with high mortality rates, and other ones are not that bad, and a patient can live with it for years and years and years, and there's a lot of really good treatments. There's not really a cure, but it can go into remission, and somebody can live with it for a really long time. So the kind of leukemia that somebody has matters. And these start on page 942 of your book. The first one is acute myeloid leukemia. And basically what you have is you have the myeloid leukemias, and it can be acute or chronic, and the lymphocytic leukemias, and it can be acute or chronic. Those are the 2 branches of the leukocytes, the white blood cells, that can develop these cancers. The acute myeloid leukemia, AML, that's the one that's really, really aggressive. Survival rates are very low. There's complications include bleeding and infection, because with all the leukemias, it is very, what's the word I'm looking for? The person gets deconditioned. And so they have a lot of fatigue, and because it's in the leukocyte system, and you know that the leukocytes are responsible for reducing infection. So if you don't have properly working leukocytes, the patient will get infection. Here's the interesting thing about the leukemias is if you draw somebody's blood, and if you'll remember, your white blood cell count should be between 4 and 10. In the patients who develop leukemias, they actually have very high white blood cell counts. So you'd think, oh, they'd never get an infection because they have such high white blood cell counts. Well, the problem is they have a lot of white blood cells, but they're completely ineffective blood cells. I mean, it's just, it would be like on a highway, if you have a traffic jam. You have a ton of cars there, but they're completely ineffective for getting you to where you want to go because there's just way too many. It's like driving in New York versus driving out on a country road. You know, you need some white blood cells, but when all of a sudden you get too many, it's just a hot mess and nothing works. That's kind of what's happening in the leukemias. And those get really specific, and you should review it a little bit, but you're not going to need to know as a nurse exactly what the serological studies mean. That's what the hematology specialists will do. You don't need to know that as much as you need to know what the signs and symptoms are and how to treat it. So signs and symptoms of the leukemias are fatigue, anemia, infection. Those are the kind of things that you want to prevent. In AML, acute myeloid leukemia, it comes on very quickly, and it is the most deadly of the leukemias. So there is treatment. They'll try chemotherapy, but it's not as effective as some of the other leukemias. The second one is chronic myeloid leukemia. Now I'm over on page 945. In chronic myeloid leukemia, this one is curable in some cases. They do still have some normal myeloid cells, and so they will have some fatigue, general malaise. They have a little bit more risk for infection, but people can live with this for a really long time. And like I said, with this one, in some cases, it can be curable. Then the next one is acute lymphocytic. Another thing I want to point out is, and you'll notice, there is a difference between acute and chronic. If your patient is developing something acutely, that means it comes on very quickly. It's never good to have something really quick, because that tends to be a little bit more aggressive than if it is chronic, because a chronic thing comes on a little bit more insidiously, and typically the body has a little bit more time to adjust to that. So chronic myeloid leukemia, wait, no, what was I on? Was I chronic? Yeah, chronic myeloid leukemia. A little bit better outcome to it. They tend to be, long-term, curable. The acute lymphocytic leukemia, ALL, acute lymphocytic, again, a little bit more aggressive. The lymphocytic leukemias are a little bit more responsive, and this one also is sometimes curable in the younger patients. So sometimes if your patient is a little kid and they develop a leukemia, they tend to, if they are responsive to therapy, and usually they have to have chemotherapy, and there are some other treatments out now, they can, the disease can be eradicated. You do kind of have to watch them, because they sometimes will, it'll reoccur later in life, and so you'll see little kids that have leukemia, they're cured or kind of in remission, and they can stay in remission for years, and sometimes it will redevelop as an adult. So they're followed pretty closely. And then the last one is the chronic lymphocytic leukemia. CLL is the most common of the leukemias, and that's the one that people can live with for a very, very long time. There's a lot of new treatments out now for all of the leukemias. Some of the chemotherapy that they have now for the leukemias are oral, so they don't have nearly the side effects of the IV chemotherapy. The side effects are much more minimal, and people can live with CLL for a long time. You do have to watch for, they can develop rashes. This is true with all the leukemias. They can develop some different rashes. They can develop anemia, bleeding, fatigue, weight loss, bone demineralization. So they have a lot of other side effects of having the leukemias, but thankfully treatment is getting pretty good for the hematological malignancies. And then the next, that's kind of it for leukemias. You can kind of read sort of about the medical management and what they do. Look at page 948, the figure 34.4. This is what I'm talking about with the swollen lymph nodes. So see under that man's axilla where you've got a lot of lymph nodes in there. You can feel that. If you feel under your axilla, you can feel those little bumpies in there. Those are lymph nodes. Those can get really swollen and engorged in patients who have leukemias. So you'll see them under the axilla. You can see up under his chin. Those are all swollen lymph nodes. And then in his abdomen, because your spleen sits right here, and your spleen is a big producer of blood cells, and your liver sits over here, so you can get a lot of lymphadenopathy, meaning, remember that word, pathy means disease of the lymphadenopathy. And that is, it's just an overproduction, enlargement, engorgement of the lymphatic system. That's really a common finding you'll see in patients who have hematological malignancies. So you want to avoid that. And we're going to talk a little bit more about that. It's also the lymphedema and stuff is common in some of the surgeries, especially if you have to cut through some of the lymph nodes when they're doing surgery, especially like with breast cancer, but we'll talk about that later. So anyways, just kind of review the leukemias. And then I wanted to talk about the myelodysplastic. I'm going to tell you about, I wanted to talk about lymphoma first. Okay, so what I'm going to do, I'm flipping over here to page 956 on the lymphomas. This is similar to the leukemias, but the thing I wanted to tell you about lymphoma is, again, there's two kinds. So with leukemia, you've got four kinds. AML, CML, ALL, and CLL. With the lymphomas, you have Hodgkin's lymphoma and non-Hodgkin's lymphoma. And again, similar to leukemia, it really matters what kind you have. Because Hodgkin's lymphoma, it's more rare. Less people have Hodgkin's lymphoma, but Hodgkin's lymphoma is much more curable than non-Hodgkin's lymphoma. So if you have to have a lymphoma, you really want to have Hodgkin's lymphoma and not non-Hodgkin's lymphoma. And what happens in the lymphomas is that there is an enlargement and unusual shaping, like it's a malignancy of the lymphocytes. That's the part of the white blood cells. The lymphocytes just get large and swollen. So, and typically what happens is in the lymphomas is that a lymphatic area will start developing and growing. The symptoms of this are night sweats, weight loss, fever. So obviously those are really vague symptoms that can show up with anything. And so typically your patient will present with some of these vague, night sweats, weight loss. Weight loss is really classic for your patients who have any kind of cancer. One sign is weight loss. So because night sweats and fever are common in, like pneumonia and, flu, but that weight loss component, that's really an indication that something else is going on, because those cancer cells are growing rapidly. And I take that back. Not always rapidly. Some of the cancers are slow growing, like some of these chronic leukocytes and lymphomas are sometimes slow growing, but they take a lot of energy and have a lot of metabolism, so that's hence the weight loss. So anyways, with the lymphomas, typically what they will do to treat a lymphoma, once they find it, once they figure out what's going on, and typically that is going to involve like a CAT scan or something like that, and they'll identify that there's this lymphoma growing there. So the leukemias don't have like a nucleus, it's just kind of in all of the vessels, but the lymphomas will typically have like an area of the lymphocytes that are kind of unusual, conglomerating, abnormal lymphocytes, and it'll show up like on an ultrasound or a CAT scan. Typically what they'll do is they'll go in and remove it, followed by radiation to that area and then chemotherapy. Most of these cancers need the chemotherapy because if you'll recall, the lymphatic system and the vascular system is all connected, and your chemotherapy targets everything. Radiation will target a specific area. So in the lymphomas, and you can have a lymphoma anywhere, they'll target the radiation right to that area. The thing you need to be aware of as a nurse is the chemotherapies will drop your white blood cell. So patients who are on chemotherapy are at higher risk for infection, fatigue. Chemotherapy will also target fast-growing cells. So your patient will lose their hair, they lose their nails, they get nauseated and vomiting because your GI tract are rapidly turning over cells, and it targets all that. But the radiation is beams that will go directly to a certain area. So like, let's say they're gonna radiate like that guy's neck. You might have some excoriation of the skin up here, some mouth ulcers. So now as a nurse, you're gonna be dealing with pain of mouth ulcers, infection of mouth ulcers, things like that. And that really becomes a nursing issue. So the Hodgkin's lymphoma tends to run in families. It tends to be a little bit more familial. The patients, if the patient is on chemotherapy, they get immunosuppressed. Non-Hodgkin's, a lot more aggressive of a disease, and the course of it is variable. I mean, it can be really, really aggressive, and a person can, have a mortality within 12 to 24 months, or some people can live with that, for 5, 6, 7 years. So those are the lymphomas that I wanted you to be aware of. Now, the next thing I wanted to go into is multiple myeloma, and now I'm over on page 960. The multiple myelomas, these are the cancers of the plasma, basically the B lymphocytes in the plasma. And if you'll recall from, I think yesterday, you'll remember I said that the plasma secretes the immunoglobulins, and the immunoglobulins help fight off infection. So these patients are at very high risk for getting infection. Survival rates for this is not good. So if your patient develops a multiple myeloma, that's not good news, and it's painful. It hurts these patients a lot. They become very anemic, so they are always gasping for breath. They're tired a lot, and that's multiple myeloma. The other thing that I wanted to talk to you guys about is where is it? The myeloplastic. The myelodysplastic syndrome on page 951. The reason I wanted to point this out is because this is what happens in myelodysplastic syndrome is it's a macrocytic anemia problem, and the blood cells, which as you know are produced in the bone marrow, so the red blood cells are still produced in the bone marrow, but the bone marrow is not releasing them into the bloodstream, and the blood cells are dying very young, and they have an abnormal development. So that's really the problem with the myelodysplastic syndrome, and it's a syndrome typically that develops after aggressive treatment. So your patients who are being treated with chemotherapy for something can then develop myelodysplastic syndrome. And a very famous case of this was Robin Roberts. Robin Roberts, who's one of the anchors on Good Morning America. She was treated for breast cancer and was undergoing chemotherapy for breast cancer, and then developed myelodysplastic syndrome, which is a very serious complication of chemotherapy. And the treatment is bone marrow replacement. And thankfully, her sister was a match for her, so she received bone marrow transplant, because the problem here with myelodysplastic syndrome is it is a bone marrow problem. It's not because the bone marrow is not producing effective blood cells. So there are two kinds. You can have a primary myelodysplastic syndrome that just shows up in the absence of like an aggressive therapy, but you can also have secondary myelodysplastic syndrome. That was the kind that Robin Roberts had, and that's actually a little bit more aggressive. So and people, especially people that have primary myelodysplastic syndrome, can then, because they have that, it can also then develop AML, acute myeloid leukemia. So patients who develop this myelodysplastic syndrome, it's a tough one to treat. But sometimes they're very effective in the treatment. Like Robin Roberts is doing great, and has actually been cured of it. Now she's back working on TV. So I did want to point that out, because that's it can be very deadly, and it's not that rare. You'll see that a lot in your patients who are being treated for cancers of all kinds of different kinds of cancers. So I think that's all I needed to tell you. Let me just look at my notes and see if I wrote down anything else. There are some other, like the myeloproliferative neoplasms, like I'm on page 953 now. Proliferative, meaning a lot of, neoplasm being malignancy, myelo being the myeloids. Your patient can have polycythemia vera, too much red blood cells, and you can see a picture of this down there on page 953. How too many red blood cells is. That's why it's called polycythemia vera, meaning like red faced. That's not super common, but you might, just sort of. Myelofibrosis, that's not super common. So really focus on the leukemia, lymphoma, multiple myeloma, and myelodysplastic syndrome. Those are the ones you kind of really need to know about. And then they do the stem cell and bone marrow transplant for the management. I think that's all you need. There are some good care plans in here, so if you end up having a patient with any of these disorders, I would refer to this and put that in your care plan, your walking care plans when you're in clinicals. Yeah, that's it. That's all you need to know. Yep, okay, good, sweet. I'll see you in class. Call if you have any questions, and we're done with hematology. All right.